Welcome to the deep dive. You've shared some fascinating stuff with us this time, a collection of articles and notes all focused on lesions in the connective tissues of the oral cavity.
Yeah, it's quite a topic.
So when we talk about connective tissue in your mouth, we're talking about the underlying support structure. Think of it like the scaffolding holding everything together.
Right.
It's made up of different types of cells, like fibroblasts, which are the main builders, macrophages, which are like the cleanup crew, and mast cells that are involved in signaling.
hmm
These cells live within what's called the extracellular matrix, a mix of fibers and a sort of ground substance that gives the tissue its strength and flexibility.
What's really interesting is that because connective tissue is so fundamental, when things go wrong, it can manifest in a surprisingly wide variety of ways. You've given us a great overview, and our goal today is, to pull out the most important insights and make sense of this complex world of oral connective tissue lesions for you.
Exactly. As we've gone through your sources, some clear categories of these lesions start to emerge. We're seeing reactive hyperplasias where the tissue is essentially overgrowing in response to some kind of irritation.
Okay, like a reaction.
Then there are neoplasms, which are true growths, and these can be benign or malignant.
Right, the more serious ones potentially.
We also have vascular lesions involving your blood and lymph vessels and neural lesions that arise from nerves. And it's worth noting there are even mentions of issues involving muscle and fat tissue in the mouth.
Yeah, it covers quite a range. If we step back for a moment, understanding these different types of lesions has real-world relevance. For instance, you might experience something common, and with this knowledge recognize it's generally not serious.
That's reassuring.
But equally important is being aware of rarer conditions that could have more significant implications for your overall health.
Definitely. Okay, let's start by looking at those reactive hyperplasias. The peripheral fibroma is one that comes up quite a bit in the sources.
Oh, yeah.
This is a non-cancerous overgrowth of tissue that happens on your gums. It's thought to originate from the connective tissue just under the surface or even from the ligament that holds your teeth in place.
Okay, so what are some of the key things to know about this type of lesion? What stands out?
Well, your sources highlight that it's more commonly seen in younger adults, and it seems to have a bit of a preference for women.
Hmm, interesting.
Location-wise, it often pops up on the gums in front of your permanent molars. When you see it, it might be attached by a stalk, like a little mushroom that's called pedunculated.
Funculated, right.
Or it could have a wider base sitting directly on the gum that's sessile. Usually it'll be the same color as your normal gum tissue, although sometimes the surface can become a little ulcerated.
Okay.
Importantly, it very rarely causes any erosion of the underlying spine.
That's good to know. The material you've provided also points out that there are two main subtypes of peripheral fibroma when you look at them under a microscope. This is a key distinction.
Right. So there's the peripheral ossifying fibroma. Let's break that down. Ossifying means it forms bone.
Okay. Bone forming.
So under the microscope, you'd see little bits of immature bone and a substance called osteoid mixed in with regular connective tissue cells called fibroblasts. These tend to have some chronic inflammatory cells around them, and the surface is often ulcerated.
Right. And the other type.
Then you have the peripheral odontogenic fibroma. This one is made up of fibrous connective tissue that has a good blood supply and it's not enclosed in a capsule. The key difference here is that it contains remnants of the tissue that forms teeth, called odontogenic epithelium.
Ah, tooth-related tissue.
Exactly, and might even have some dentin-like material. This subtype is usually not ulcerated. So the main takeaway here is that while they might look similar on the surface, what's going on microscopically gives us important clues.
Yeah, absolutely. It's worth emphasizing that these are distinctions we make by looking at the tissue under a microscope. Clinically, both subtypes can appear quite similar. However, understanding the general microscopic features of a peripheral fibroma gives us more context.
Exactly. Generally, a peripheral fibroma is very collagen-rich, meaning it's dense with strong fibrous protein, and it doesn't have a lot of blood vessels.
Relatively vascular, yeah.
You might see some mild inflammation, likely a leftover from whatever triggered the initial overgrowth. Your sources even draw a parallel to a traumatic fibroma, which is basically the same thing but occurring in other areas of the mouth's lining.
Okay, similar idea, different spot.
Yeah.
And how are these peripheral fibromas typically treated?
The usual approach is a straightforward surgical removal. If the periodontal ligament, that's the tissue connecting the tooth to the bone, seems involved, that needs to be addressed too.
Makes sense.
It's also important to remove any local irritants like plaque or tartar buildup on the teeth. Now, the ossifying fibroma subtype has a higher chance of coming back.
Ah, recurrence risk.
Yeah, so for those, the surgeon might need to go a little deeper, removing tissue down to the bone covering or the periodontal ligament to prevent recurrence.
Right, more thorough excision for that type.
Uh,
Moving on to another common reactive lesion, we have focal fibrous hyperplasia. What's the story with this one?
This one is really a direct result of repeated minor trauma to the lining of your mouth. Think of it as your body trying to repair an area that keeps getting irritated, and it just lays down a bit too much scar tissue.
Like an over-enthusiastic repair job.
Pretty much. It's a very common reactive response, and you typically see it in areas that get bumped or rubbed a lot. The inside of your cheek, the side of your tongue, and the lower lip are frequent spots. Clinically, it's a painless lump with a broad base, and because it's so dense with collagen, it often looks paler than the surrounding tissue due to a reduced blood supply.
Less vascularity.
Exactly. If it gets quite large, it might get accidentally bitten or scraped, leading to a bit of surface ulceration. However, these tend to stay relatively small, usually not getting much bigger than a centimeter or two.
Okay, limited growth potential then.
So the key insight here is that this is your body's repair mechanism in overdrive due to chronic irritation.
And what do we see under the microscope with focal fibrous hyperplasia? Is what you'd expect?
Not surprisingly, yeah, it's all about an overproduction of collagen. You'll see mature fibroblasts, those connective tissue builders, scattered throughout this dense collagen network.
Lots of collagen.
There might be a few chronic inflammatory cells, often clustered around small blood vessels, and the surface lining, the epithelium, is often thickened a reaction to that ongoing friction.
Hyperkeratosis, perhaps.
Often.
Okay. And the treatment for focal fibrous hyperplasia? Pretty straightforward.
Usually, a simple surgical removal is all that's needed. It's not likely to come back unless the source of the trauma continues.
Right. Got to remove the irritation source if possible.
And importantly, these are completely benign with no risk of turning into cancer.
Good to know. Next, we have denture-induced fibrous hyperplasia, also known as epulis fissuratum. The name itself really points to the cause, doesn't it?
Absolutely. This one is specifically linked to the chronic rubbing and irritation from dentures that don't fit properly.
Ill-fitting dentures, classic cause.
You might also hear it called inflammatory hyperplasia or denture hyperplasia, but epulis fissuratum is the classic term. When you see it, it's most often in the vestibule of the mouth. That's the space between your cheeks and gums.
The sulcus.
And sometimes along the inner side of the lower jaw in people who've been wearing dentures for a while. As your jawbone naturally shrinks over time after tooth loss, dentures can become loose, and the constant movement and pressure on the gums create these painless folds of excess fibrous tissue right around the edges of the denture.
Ah, so it forms right where the denture flange sits.
Precisely. So the crucial thing to understand is that this is a direct consequence of ill-fitting dentures causing ongoing trauma.
And the treatment strategy here is pretty clear, isn't it? It's not just about the lesion itself.
Exactly, because that excess scar tissue is essentially permanent. Just getting a new denture or having your old one relined won't make it go away.
Right, the tissue's already there.
Surgical removal of the extra tissue is usually necessary. But, and this is critical, you also have to address the poorly fitting denture to prevent the hyperplasia from coming back.
Makes sense. Fix the cause.
It's a two-pronged approach.
Definitely. Let's now turn our attention to generalized gingival hyperplasia. This is different as it affects, well, the entire gum area, right?
That's right. Here you see an overall excessive growth of the gum tissue, and it's usually a result of long-term inflammation caused by the usual suspects: plaque, calculus, and bacteria.
The common culprits for gum inflammation.
It can range from a mild swelling of the little triangles of gum between your teeth, the interdental papillae, to a really significant overgrowth that can almost completely cover the crowns of your teeth.
Wow, quite a range.
Now, a key point is that not everyone's gums react the same way to the same amount of local irritation. This suggests other factors are at play.
And as your sources highlight, this variability in response often points to specific medications, hormonal changes, or even underlying medical conditions. There are some well-known associations.
Exactly. We see some strong links here. Phenytoin, also known as Dilantin, which is used to control seizures, is a well-known culprit.
Classic example.
It's thought to interfere with how your gums break down old collagen, leading to a buildup of tissue. Interestingly, even though the drug plays a role, local factors like plaques still make it worse, and around half of patients taking phenytoin might experience this.
So hygiene is still key even then.
Absolutely. Then there's cyclosporine, an immunosuppressant drug. The exact mechanism isn't fully understood, but it might involve fluid buildup due to increased production of certain substances by gum cells.
Hmm. A different mechanism, perhaps.
The good news with cyclosporine is that the gum overgrowth often goes away if the drug is stopped.
Oh, so potentially reversible.
Right. So a key takeaway is that certain medications can significantly impact gum tissue.
Yeah, definitely. The sources also mention other drugs in this context, don't they? Calcium channel blockers.
Yes, nifedipine and other calcium channel blockers used for things like high blood pressure can also cause gum overgrowth, and they seem to have a similar effect to phenytoin. However, like cyclosporine, the side effect appears to be reversible if the medication is discontinued.
Unlike phenytoin, you noted. Interesting.
Hormonal shifts, such as those during pregnancy and puberty, are also associated with increased gum tissue, though the old term pregnancy gingivitis is a bit misleading. Again, local factors like plaque play a major role.
Right. Hormones plus plaque.
Finally, certain blood cancers, especially chronic monocytic leukemia, can lead to gum enlargement because the cancerous white blood cells infiltrate the gum tissue.
Oh, wow. That's a serious underlying cause.
This type of overgrowth often looks red and bleeds very easily, which is quite different from the firmer overgrowth seen with phenytoin. So it's important to note that different causes can lead to different appearances.
That's a really important clinical distinction. So, in general, what are the clinical signs of generalized gingival hyperplasia? What would someone notice?
You'll typically see an increase in the size of both the unattached and attached parts of the gums, particularly those papillae between the teeth.
The interdental areas get bulky.
Yeah, the gums might lose their normal stippled appearance, the edges might look rounded and thickened, and the firmness can vary. They might feel soft and spongy, especially with cyclosporine-related overgrowth, or quite firm and dense in other cases.
Texture can vary.
The color can also range from a reddish blue, if there's a lot of inflammation present, to a lighter pink.
Okay. And under the microscope, in cases of generalized gingival hyperplasia, what's the common theme?
You'll generally see a lot of collagen and an increased number of fibroblasts. The amount of chronic inflammation present will vary depending on the cause.
Makes sense.
In cases linked to hormones, you might see more small blood vessels and a type of immune cell called plasma cells. If it's leukemia-related, you'd see those abnormal, immature white blood cells within the gum tissue.
So the histology reflects the underlying cause, too. And the foundation of treatment for all these types of generalized gingival hyperplasia, what's the most crucial part?
Meticulous oral hygiene is absolutely essential to minimize the inflammation.
Hygiene.
Procedures like gingivoplasty or gingivectomy, where the excess gum tissue is surgically reshaped or removed, might be necessary, but these are always done in conjunction with professional cleanings, thorough instructions on how to care for your teeth and gums at home, and a consistent home care routine. The key takeaway here is that managing inflammation is paramount.
Absolutely. Okay, let's now move into the category of neoplasms, starting with fibrous neoplasms. The first one we encounter in the sources is myxomoma.
Myxoma, right. This is a relatively rare, benign, soft tissue growth that has a rather unique description. It's characterized by a jelly-like material, almost like what you find in the umbilical cord.
Yeah.
And under the microscope, it has a myxoid appearance, meaning it looks somewhat slimy or mucus-like. In the mouth, it's quite uncommon and usually shows up as a slow-growing, painless lump under the surface, most often on the palate.
Palate is a common spot.
Seems to be. It doesn't seem to prefer one gender over the other and can occur at any age.
Okay. What are some of the challenges associated with myxomas? Are they straightforward?
Well, your sources point out that these tumors aren't encapsulated, meaning they don't have a well-defined border.
Not nicely contained.
Right, and they can even infiltrate the surrounding soft tissues, which can make complete surgical removal difficult. Microscopically, you see these scattered, star-shaped and elongated fibroblasts within that loose myxoid background.
Skelly cells, yeah.
The treatment is surgical removal, but unfortunately, they have a tendency to come back, so careful follow-up is needed.
High recurrence rate, then.
Seems so. However, because they are benign, conservative surgery is the appropriate approach. So the important thing to remember is the potential for recurrence despite being non-cancerous.
Got it. Benign but tricky to fully remove. Next in the fibrous neoplasm category is fibromatosis. This one sounds a bit more aggressive just from the name.
Yeah, fibromatosis refers to a group of benign but locally aggressive growths. They have a tendency to infiltrate into surrounding tissues, can be destructive, and have a high rate of recurrence after treatment.
Locally aggressive, that's the key term.
However, they don't typically spread to distant parts of the body, so no metastasis. Clinically, they often present as firm, painless masses, and in the mouth, the lower jaw and the soft tissues nearby are the most common locations. They tend to grow slowly.
Okay. Given this locally aggressive behavior, what's the recommended course of action? How do you manage that infiltration?
Because of the high chance of recurrence, which can be anywhere from 20% to 60%, and their ability to destroy local tissues, a more aggressive surgical approach with wider margins is usually recommended to try and remove all of the abnormal tissue.
Or excision, yeah.
While they don't usually metastasize, some cases, especially in the head and neck region, have unfortunately been fatal due to their extensive local spread.
Wow. So benign, but still potentially very serious due to location and spread.
Exactly. So the key takeaway is their locally aggressive nature, despite being technically benign.
Right. The last of the fibrous neoplasms we'll discuss is fibrosarcoma. The sarcoma part of the name immediately tells us it's malignant.
Exactly. Fibrosarcoma is a rare malignant tumor that arises from spindle-shaped connective tissue cells. Under the microscope, these cells are arranged in an interlacing pattern, like woven fibers.
Herringbone pattern, sometimes described.
And they don't show characteristics of other types of connective tissue cells. Clinically, it can start as a growing mass of these cancerous cells, and as it enlarges, the surface might ulcerate. It tends to affect younger adults and is more of a local problem, meaning it infiltrates and destroys nearby tissues rather than primarily spreading to distant sites in the body.
So local control is the main challenge.
That seems to be the case.
And how is fibrosarcoma typically managed then?
Because it's difficult to control its local growth, wide surgical removal is generally the primary treatment. Even with surgery, recurrence is common, but fortunately it doesn't tend to spread to distant sites as frequently as some other cancers.
Okay, wide surgery, monitor for recurrence. Got it. Let's shift gears again and discuss vascular lesions, starting with lymphangioma.
Lymphangiomas, right? These are considered to be congenital, present at birth, and usually become apparent in the first 2 decades of life. They're essentially malformations of the lymphatic vessels.
Lymphatic system, not blood vessels primarily.
Correct. Unlike hemangiomas, which are blood vessel malformations, lymphangiomas typically don't shrink or go away on their own over time.
They tend to persist.
Yeah. Clinically, if they are near the surface, they can look like painless, bumpy, blister-like swellings. If they're deeper, they might just present as a soft mass under the skin.
Like little vesicles sometimes.
Exactly. The color can range from normal skin tone to reddish blue if there are some blood vessels mixed in. A characteristic finding when you touch them is that they might feel a bit squishy and produce a sort of crackling sound as the lymphatic fluid is moved around.
Fabulous.
The tongue is the most common location in the mouth, and if the lymphangioma is widespread, it can cause the tongue to become significantly enlarged, a condition called macroglossia.
Oh, wow, big tongue.
So the key thing to remember is their congenital nature and tendency to persist.
Okay. What does the microscopic examination reveal for lymphangiomas?
Under the microscope, you see numerous channels lined by cells called endothelium, which are the cells that line lymphatic vessels. These channels are spread diffusely throughout the connective tissue beneath the surface.
Diffuse lymphatic channels.
They don't have a surrounding capsule, and a notable feature is how close these lymphatic channels are to the overlying skin or mucous membrane, often right underneath it.
Subepithelial location.
Right.
And what are the treatment options for lymphangioma? Are they easy to treat?
Surgical removal is often attempted, but because they lack a clear boundary and tend to be diffuse,
That lack of encapsulation again?
it can be difficult to remove them completely, leading to frequent recurrences. Another treatment option is sclerotherapy, where a special solution is injected into the lesion to cause the vessels to swell and eventually close off, which can help to reduce the size and make them less noticeable.
Sclerosing agents. Okay, so surgery or sclerotherapy, but recurrence is common.
Seems to be the challenge.
Now, let's delve into neural lesions, starting with the reactive one. Traumatic neuroma.
Traumatic neuromas, yeah, these are a direct consequence of an injury to a peripheral nerve. In the oral cavity, this can happen during procedures like tooth extractions, from local anesthetic injections, or due to accidental trauma.
Nerve gets cut or damaged.
Exactly. When a sensory nerve is cut or damaged, it can lead to inflammation and the formation of scar tissue at the injury site. And this can trap the nerve endings, leading to a traumatic neuroma.
Nerve tries to regrow but gets stuck in scar tissue.
That's a good way to put it. Clinically, it presents as a small, slightly raised, firm bump that is very sensitive to pressure.
Painful to touch.
Very. Common locations include the groove in your lower jaw near the mental foramen, near the front teeth, in the area behind the last molars on the tongue side and on the underside of the tongue. Sometimes they can be below the surface and not easily visible.
Um,
A key sign is that pressing on it will often elicit a sharp, electric shock-like sensation.
the electric shock sign. Classic.
These lesions develop after the nerve injury and will persist until treated. So the main thing to remember is that this is a painful reaction to nerve damage.
And what does the microscopic view show us for a traumatic neuroma?
Histologically, you see a disorganized tangle of nerve fibers mixed in with dense, collagen-rich scar tissue. The normal parallel arrangement of nerve fibers is lost.
Haphazard nerve bundles and scar.
Pretty much.
Treatment for traumatic neuroma is usually quite effective, right?
Yes, surgical removal of the neuroma is the typical treatment, and thankfully they don't usually come back.
Good prognosis then. Okay. Moving to the neoplastic neural lesions, the first is granular cell tumor.
Granular cell tumor. This is an uncommon benign growth of unknown origin, although it's thought to arise from Schwann cells, which are cells that support nerve fibers.
Schwann cell origin, but the cause isn't certain.
Right. Clinically, it tends to occur in middle-aged adults, with a slight preference for women. The tongue is by far the most common location in the mouth, but it can occur anywhere.
Tongue is a hot spot.
Seems like it. It usually presents as a small, uninflamed, and painless lump, typically less than 2 centimeters in diameter, and often has a yellowish hue on the surface with the overlying tissue intact. Occasionally, multiple lesions can be found.
Yellowish, painless lump on the tongue.
Yeah.
Often.
Okay.
And the treatment approach for granular cell tumor.
Simple surgical removal is the standard treatment, and these tumors generally don't recur. So it's a straightforward, benign lesion.
Benign. Good outcome. Next is schwannoma, also known as neurilemoma. Here we do know the specific cell type it originates from, right?
Exactly. Schwannoma is a benign tumor that develops from the Schwann cells of the nerve sheath. As it grows, it pushes the nerve aside rather than growing within the nerve itself, which distinguishes it from something like a traumatic neuroma.
Pushes the nerve, doesn't invade it.
Correct. Clinically, it's usually an encapsulated mass under the surface that presents as a painless lump. It can occur at any age, and the tongue is a common site again, although it can be found throughout the mouth. They tend to grow slowly, but can sometimes have a sudden increase in size.
Encapsulated, slow growing, usually.
Yes.
The microscopic appearance of schwannoma has some distinctive patterns, doesn't it? Antony A and B.
Yes, it does. Very characteristic. Under the microscope, the Schwann cells arrange themselves in 2 main ways. In areas called Antony A, the cells are very dense and organized in palisading patterns, often forming swirling arrangements around a central acellular area known as a Verroquet body.
Verroquet bodies, right? The organized pattern.
And in Antony B areas, the cells are less densely packed and more randomly distributed within a looser, more fibrous, sometimes microcystic tissue, the less organized pattern.
Right.
And treatment for schwannoma is typically quite successful, given it's encapsulated.
Yes, surgical excision is the standard treatment, and recurrence is very unlikely, leading to an excellent prognosis.
Great. Now we come to neurofibroma, which can occur as a single lesion or, importantly, as part of a more widespread genetic condition.
Right, this is a key distinction. Solitary neurofibromas have no known cause and can appear at any age as a painless lump under the surface. The tongue, inside of the cheek, and the vestibule are common oral sites. Treatment is a simple surgical removal, and they are unlikely to return.
Okay, the solitary ones are usually simple.
Microscopically, both solitary and multiple neurofibromas show spindle-shaped cells with wavy nuclei in a delicate connective tissue that might have a slightly jelly-like or myxoid appearance. They can be well-defined or blend into the surrounding tissue.
Wavy nuclei, delicate stroma.
However, when you see multiple neurofibromas, especially in the oral cavity, it often raises suspicion for neurofibromatosis type 1, also known as von Recklinghausen's disease of the skin. NF1, yeah. The systemic condition?
This is a genetic condition passed down through families, often autosomal dominant, that involves the growth of multiple neurofibromas throughout the body, as well as characteristic light brown spots on the skin called café au lait macut,
The coffee spots?
bone abnormalities, and changes in the nervous system. There's also a slightly increased risk, around 5% to 15% of these neurofibromas becoming cancerous, transforming into a neurogenic sarcoma.
Malignant transformation risk. That's important. There are specific clinical signs that help diagnose neurofibromatosis type 1, aren't there? Beyond just multiple neurofibromas.
Yes, there are specific criteria. Having 6 or more café au lait macules larger than 1.5 centimeters is a key diagnostic criterion.
6 or more. Specific size.
Other important signs include freckling in the armpits and groin area, known as crow's sign,
Axillary freckling.
and small benign tumors on the iris of the eye called Lisch spots.
With nodules on the iris.
In these cases, while any symptomatic oral neurofibromas might be surgically removed, recognizing that it's part of a systemic condition is vital, and the patient needs to be referred to a medical specialist for comprehensive evaluation and management.
Absolutely critical for proper care.
So the key here is recognizing the potential link to a broader health issue.
Definitely. Finally, in the realm of neurolesions, we have the oral manifestations seen in multiple endocrine neoplasia syndrome type 3, or MEN3, also called MEN2B.
MEN syndromes. Right. These are a group of inherited conditions where tumors develop in multiple endocrine glands. MEN3, which is also passed down through families typically autosomal dominant, is unique in that it can have noticeable oral features in the form of mucosal neuromas.
Mucosal neuromas is an early sign.
This syndrome involves a specific type of thyroid cancer called medullary carcinoma, tumors of the adrenal gland called pheochromocytomas, and these characteristic mucosal neuromas. Patients might also have café au lait spots and skin neurofibromas, similar to NF1 sometimes.
Thyroid cancer, adrenal tumors, and the neuromas. A specific triad.
Exactly. The oral neuromas in MEN3 often appear early in life as small, discrete bumps on the conjunctiva of the eye, the lips, the larynx, or within the oral cavity itself, particularly on the tongue, lips, and inside of the cheeks.
Appear early, often multiple small nodules. The microscopic appearance of these mucosal neuromas is quite distinctive, as I recall from the sources. Pathognomonic, even.
Yes, under the microscope, they show as wavy, band-like clusters of nerve tissue surrounded by normal connective tissue. It's often described as having a spaghetti-like appearance, and yes, it's considered pretty characteristic or pathognomonic.
Spaghetti-like nerve bundles.
While these oral neuromas themselves are benign and treated with surgical removal without expected recurrence, their early identification is incredibly important.
And why is early detection so crucial in MEN3? What are the bigger risks?
Because the other components of the syndrome, particularly the medullary carcinoma of the thyroid, can be aggressive and can spread early. The 5-year survival rate is only around 50%.
Wow, that's serious.
And the pheochromocytomas, while usually benign adrenal tumors, can cause dangerously high blood pressure and other cardiovascular problems due to the overproduction of hormones like adrenaline and noradrenaline.
Catecholamine release, causing hypertension crises.
Exactly. Therefore, a dentist who recognizes these early oral neuromas can play a critical role in the early diagnosis of this potentially life-threatening syndrome, allowing for timely medical intervention, genetic testing, and potentially saving the patient's life.
That's a huge point. The dentist's role in spotting systemic disease.
It really underscores how oral health can be a window to overall health.
Absolutely. Okay, let's move on briefly to neoplasms of muscle tissue, which the sources note are quite rare in the oral cavity.
Yeah, much less common. We have smooth muscle tumors, leiomyoma, which is benign, and leiomyosarcoma, which is malignant.
Smooth muscle first.
Oral leiomyomas are typically slow-growing, painless lumps under the surface, often found on the tongue, hard palate, or inside of the cheek, and they're usually small, like 1 to 2 centimeters. Microscopically, you can have some similarities to neurofibromas and fibromatosis sometimes.
Can be tricky to differentiate sometimes histologically.
Leiomyosarcomas, being malignant, are treated with wide surgical removal, and unfortunately, they have a tendency to spread, often to lymph nodes or the lungs.
Metastasis is a concern.
Then we have skeletal muscle tumors, rhabdomyoma, which is benign, and rhabdomyosarcoma, which is malignant, also rare orally.
Skeletal muscle now.
Oral rhabdomyosarcomas most commonly occur on the floor of the mouth. soft palate, tongue, and inside of the cheek, with an average age of diagnosis around 50, although they can occur in a wider age range, including children. They often present as a painless, well-defined lump under the surface.
Can affect children too, that's notable.
Treatment usually involves a combination of surgery, radiation therapy, and chemotherapy, which has significantly improved survival rates for this aggressive cancer, from less than 10% historically to over 70% now.
Much better outcomes with combined therapy. Good. Finally, let's discuss neoplasms of fat tissue, lipomas, and liposarcomas.
Latomas are uncommon benign tumors of fat that can occur anywhere in the oral cavity, with the inside of the cheek, tongue, and floor of the mouth being frequent sites.
Fatty tumors.
They typically present as soft, painless, yellowish lumps under the surface, and the overlying tissue usually looks normal, although you might see some small blood vessels on the surface. A simple lipoma is a well-defined collection of mature fat cells.
Yellowish, soft, submucosal.
Treatment is surgical removal, and they are not expected to recur.
Usually simple excision.
Liposarcomas, the malignant counterparts, are very rare in the head and neck region. They can occur at any site and often grow slowly, sometimes mimicking benign lipomas, which can be tricky.
Can look benign initially.
Because of their potential to be aggressive, depending on the subtype and differentiation, it's really important that any suspected lipoma that presents unusually or grows rapidly should probably be biopsied to rule out liposarcoma.
Biopsy is key if suspicious.
Treatment for liposarcoma usually involves surgery or radiation therapy, and the prognosis can vary depending on the specific microscopic type and how well differentiated the tumor cells are.
Prognosis depends on the specifics.
So the key takeaway here is that even seemingly simple fatty lumps might need investigation to rule out something more serious.
Good point. So as we've thoroughly explored, the oral cavity can indeed be affected by a remarkably wide spectrum of connective tissue lesions. It's quite the landscape.
Absolutely. From those everyday reactive responses, the hyperplasias, to the much rarer neoplastic conditions, both benign and malignant, they really do exhibit a huge variety of behaviors and potential implications for your health.
Yeah, quite a range. And as we've seen throughout this discussion, getting to the right diagnosis depends heavily on carefully observing the clinical presentation, what it looks like, where it is,
Right.
then examining the tissue under a microscope, the histopathology.
Crucial.
And sometimes, as we saw with the hyperplasias and the syndromes, even considering the patient's overall medical history and medications.
Here's where it gets really interesting for me. That aha moment, maybe. Realizing that even something that seems like a localized issue in your mouth could actually be an early warning sign of a more widespread systemic condition, like those mucosal neuromas in men 3.
Yeah, exactly.
It really drives home how interconnected our oral health is with our overall well-being.
It really does. And this brings up a really important point for you, the listener, to consider. Given the diverse origins and appearances of these lesions we've discussed, what other seemingly isolated changes in your health might actually warrant a deeper look into underlying systemic factors?
That's a provocative thought.
It's a good reminder that our bodies are constantly giving us signals. And even the subtle ones we notice in our mouths can hold crucial information about our general health. Don't ignore them.
Absolutely. So if any of these particular lesions have sparked your curiosity, or if you have any further questions after this deep dive, please do reach out. We encourage you to explore the topics that resonated most with you.
Yeah, definitely dig deeper if something caught your interest.
Thanks for joining us on the Deep Dive.